everyone, and welcome to this new video on running technique and running injury. Today we're going to focus on a very common running injury, which I'm sure many of you watching this either have or have suffered with in the past, and that's dysfunction surrounding the iliotibial band or IT band, which is a tendon that runs down the side of your thigh. So first of all, I'm going to go through the anatomy of the area so you can better understand why the injury happens, and then we're going to have a look at the injury mechanism, so how it happens, and also gait characteristics, so you can identify the risk factors and your own running technique about why it might occur. And then finally I'm going to give you some corrective exercises on what you can do to combat it if you do suffer with it. So firstly, let's have a look at where the IT band sits within the body and what muscles it attaches to. If we start from the top, as you can see, it attaches into the pelvis and the glute medius and glute maximus muscles, which we're going to talk about in more detail shortly. The TFL muscle, which is responsible for abduction of the thigh and flexion of the hip, also blends into the IT band. If you look further down the leg, you can see that the ITB tendon runs down the outside of the thigh alongside the vastus lateralis muscle. It goes past the outer knee and attaches just very slightly below the knee joint on the top of the tibia bone. The site of pain with this injury is the fat pad on the outer knee, which gets inflamed. The video clip that's now playing on your screen shows a common running gait characteristic that often puts strain along the IT band. As it plays through, pay particular attention to what's going on around the pelvis. The screenshot on the left shows the left leg in the stance phase of the gait cycle, i.e. acting as the driving leg on the ground. Here you can see that the pelvis remains relatively level, so there isn't a significant drop of the right hip. In this situation, the right side is known as the contralateral side, because the right leg is not in contact with the ground. However, let's now compare that with the screenshot on the right of your screen, which is taken in the same part of the gait cycle, but this time with the right leg doing the driving and the left leg being the contralateral side. Notice the position of the pelvis here. You can quite clearly see how the left hip drops down much more than the right hip did. This is known as a Trendelenburg gait. But now let's have a look at that a bit more closely. What is actually causing this hip drop to occur, and what about this is causing the injury? Well, to answer those questions, we first need to think about the main muscle groups that should be operating to keep that pelvis level. So to stop the left hip from dropping, there needs to be an effort coming from the glute medius muscle, as well as the upper fibers of the glute maximus on the right side. When these muscles engage, it will pull the pelvis up slightly on the other side. However, we also need to consider the muscles on the contralateral side here as well, specifically the obliques, because if the obliques engage properly, they too will prevent the contralateral hip from dropping down. Therefore, as you can see, it's essentially a seesaw effect. If these muscles engage properly, the pelvis will stay level. If they don't, you start to see the Trendelenburg gait show through. So why is this a risk factor for developing runner's knee? Well, as the opposite hip drops down, you will get essentially a stretching through the right IT band with every stride where the right leg is doing the driving. This pulling then irritates and inflames the fat pad around the outer knee. It's also worth mentioning that this hip drop could be attributed to potential lower back issues on the contralateral side, as every time this hip drops, excessive lengthening strain is then put through the QL muscle. Another thing to notice from this screenshot is where the right foot is landing in relation to the midline compared to the left. This is something I covered in an earlier video about medial tibial stress syndrome, or shin splints. This likely occurs here because of a compensatory mechanism whereby the muscles I've just mentioned are too weak to hold the pelvis level. So in order to maintain balance and stability, the foot then comes further across the midline. Here you might also notice a lateral heel flick during the recovery phase of the affected leg, which is noticeable from behind. Because as the knee comes in, the heel has to flick outwards. However, this travel across the midline can also exert extra strain onto the IT band as well. Let me now show you something very similar in another runner from the front. Sometimes you'll notice the knee collapses in due to lack of engagement from the glute medius muscle, which puts more lengthening stress into the IT band. This knee collapse is known as knock knee, and you may even see the knees actually brushing together. This issue is more common amongst female runners because wider hips result in a sharper angle from the pelvis down to the knee. So it's easier to allow the knee to collapse in when this muscle is weak. Because of the overlap with previous content, if you are after some technical drills to prevent this knock knee movement from occurring, I would recommend checking out my MTSS video. The first exercise we're going to do is what's known as the hip hitch. Now this is a really simple exercise. All we need is a step or something similar, and we're going to stand on the very outside of the step and allow our other leg to sort of hang down a little bit. So this is essentially going to simulate the hip drop. So what we're going to do, we're going to bend the knee slightly so we're not locking everything out, and we're just going to gradually allow the pelvis to tilt sideways down just to simulate that Trendelenburg gait, that hip drop. Okay, and once we can feel that tilt and it's noticeable, we're going to put our hand on our glutes, which is particularly important if you do struggle to activate your glutes anyway, because that's going to develop that mind-muscle connection and give you that extra little bit of feedback. And we're going to squeeze this area to bring our pelvis back level. Okay, and we also need to squeeze our core throughout as well. So we're just going to gradually lower ourselves down, and the lowering bit is good as well because that provides a little bit of eccentric lengthening stress to the muscle, which is obviously effective at developing strength. And then we're going to squeeze and bring it back up to the top. Okay, so this is as much a brain retraining exercise as it is a strengthening exercise. Okay, a common mistake that people make with this is that they use their lower back in order to do the work instead, and they sometimes sort of shorten around here, you might see. Okay, obviously we don't want to do that. We don't want to overwork the QL muscle in our back, so we want all the work to be coming from our glute medius and upper glute max. Okay, I'm just going to show you from the other side. Okay, and one final point is that if you do struggle to balance with this exercise, you can always touch something just to maintain that balance, but of course don't lean on it because we don't want to be reliant on it. Okay, we want our stability as much as possible to come from our intrinsic muscles, i.e. the glutes. This next exercise is going to target both the glute medius and glute max muscles and also the oblique muscles as well. So essentially what we're going to do, we're going to start off laying on our side. We're going to bend our bottom knee and we're going to come up into essentially a half side plank. So we need to make sure that we're not leaning forward like that or leaning back. So what you should find is that the glute medius and the oblique muscles on the bottom side should be engaging already. But what we're going to do, we're also going to work the top as well. So we're going to work the glute medius, glute max at the top. So we're going to bring our leg up and then we're going to bring it back and then forward and down. So when we bring our leg back, we want to make sure that there's no bend in our knee like that. But also we want to make sure that we're not bringing it back so far that we're going to have the temptation to lean backwards. Okay, so we don't actually need to bring it back that far, just enough so that we can feel the intensity rise a little bit. Okay, now once you've progressed through this one and this starts to get a bit easy, then you can go up into a full side plank and then do the same exercise. So again, make sure that we're not tilting forward or back, and we're just going to bring our leg up, back, forward and down. So up, back, forward and down. So I really like this exercise because, as I mentioned earlier on, there are obviously factors at play on the contralateral side, as well as obviously the glute medius and glute max muscles on the affected side as well. Okay, so that's why we get this sort of hip drop. So if we do get a hip drop, so say our left hip is dropping, like in the example that I gave, then this exercise is really good, because if you then lay on your left side, then it's going to target the obliques that we need, of course, to be engaging to pull that pelvis up, and also the glute medius and glute max muscles. One thing that you can also do if you do suffer from ITB syndrome is you can foam roll in order to manage the symptoms until such time you're able to book in for a full biomechanical assessment. However, please do be aware that obviously foam rolling isn't a cure, it's only going to treat the symptoms, okay? So in the absence of actually finding the cause of the injury, all we're doing is essentially managing the dysfunction and managing the pain a bit better, but of course we're still doing damage to ourselves. So please do bear that in mind. So foam rolling should never be used for anything other than general maintenance. However, if you do want to know how to foam roll your IT bands, then do check out day 1 of my foam rolling challenge that I did recently. Finally, I just want to reiterate that obviously I hope this video has helped, and that it has identified some exercises that you can be getting on with if you do have this injury. However, of course, please be aware that it is always best, if you can, to book in for a full biomechanical assessment if you do suffer from a specific injury, because then you stand the best chance of getting the best outcome possible. Take care, and I'll see you again soon.